Good morning, everyone. This is Karina Hill with the Florida Alcohol and Drug Abuse Association, and I would like to welcome everyone to today's webinar. Hopefully you had a great holiday weekend and got plenty of rest. Today we will have our webinar entitled Trauma-Informed Care, Suicidality and Motivational Approaches for Substance Use with Trish Caldwell. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Couple things. You are in listen-only mode and will only be able to view your name. If you have any questions, I would appreciate it if you would just send it through the chat panel rather than the Q&A panel. And when you send it through chat, make sure you're selecting to the presenter and the host so that we both can see your questions. Please send your questions again through the chat panel and we will answer them as time permits. Our broadcast is brought to you through our internet, through your internet to your computer. If you experience poor computer audio, there are a few options that you can try on screen right now, and these options are also posted in the chat panel too. If you continue to experience poor audio through your computer, you want to try rejoining the webinar and call in using the telephone I will call in option. One note is you must be connected to the audio of this presentation and also view it on screen to receive a certificate of credit. So you again must also view it and hear it. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. However, we do have the presentation available on our site now if you'd like to print that ahead of time before the presentation gets started. The archive video displays what looks like to be an error message, but it's only a delay buffer, so you can ignore it, hit play, and enjoy. To access the recording in PowerPoint, you will go to our website at www.fada.org to our Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 30 business days, and that is after the evaluation closes. The evaluation will close on Friday, September the 11th at midnight, and it will be posted in your individual professional development journal for persons completing the evaluation and attending the entire webinar. Again, it does take up to 30 business days for your statement of credit to be issued after the evaluation closes. 1 to 2 continuing education credits are available for participating in today's webinar. For persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx does monitor your arrival and departure, so it's important that you attend the entire webinar as we will be provided a report upon completion of the event of your attendance. Again, it's important that you attend the entire webinar to receive credit. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to give partial credit. And with that being said, I'd like to introduce our presenter, Trish Caldwell. She's been with us before, and we have thoroughly enjoyed her presenting. She is with the Family Services Corporate Director for Recovery Centers of America, an adjunct professor at Jefferson University, and a trauma trainer for Lakeside Global Institute. Trish is a licensed clinician, marriage and family therapist, and is certified in both co-occurring disorders and substance use. Trish has been a therapist for over 25 years and has worked extensively with families, young adults, and adolescents with co-occurring behavioral health and substance use disorders in various settings, including outpatient, residential, schools, and community agencies. She is trained in DBT and is a certified trauma professional. And with that being said, Trish, I would like to go ahead and introduce you. Are you ready to get started?
I am.
Okay, I'm going to turn that over to you now.
Terrific. Thank you so much. Thank you, everybody, for participating today. I am eager would be an interesting word to use, but I am actually eager to start a conversation about trauma-informed care, which is a strong passion of mine in regards to substance use treatment, and highlighting the interactional relationship that we sometimes see for those that have a substance use disorder, have been impacted by trauma, and what we're noticing in regards to suicidality. So we're going to talk a lot about that today and kind of break it down in talking about trauma and talking about suicidality, and then integrating. So how do we start to work with this? What do we need to understand differently so that the treatment that we are providing is both effective, is utilizing some of the treatment approaches that we have identified as evidence-based, so that we can all do the same goal that we have, which is moving our patients through this continuum so that we can help them to find sustainable, meaningful lives in the recovery and healing of both their trauma and their substance use. So I appreciate the introduction. As we go through this, what I'm going to encourage you to do as well, and you just heard that earlier, is if you have any questions, I like answering the questions live rather than waiting for a set time period, because I think it loses some of the momentum of if you have a question about a certain slide, coming back to it, I think can sometimes be disruptive. So if you have any questions while we're going through this, please feel free to use it in the chat box. If you do use the Q&A, I will try and search through that as well, but make sure that you send those questions myself. I will go through and kind of see how and when the questions are coming through so I can answer them appropriately. And if I miss any, we'll make sure that we come back to them, particularly after the break. Also, just as a heads up, so we will be giving you a 5-minute break. So I'm going to probably end as close to 11 o'clock as possible to give you that 5-minute break, and then we'll come back for the conclusion of the training. So these are the objectives. Ordinarily, I say the objectives are everything that I'm going to go over, so I don't necessarily need to go over them. But I'm going to highlight them just for a couple of minutes here as we go through this. So we are going to discuss what trauma-informed care is as articulated by SAMHSA. So I'm going to go through those 6 principles. We're going to talk a little bit about the shared symptoms of trauma and substance use, which does include suicidality. So that's a huge, important piece for me in regards to our understanding of those that we are serving. So what are these symptoms so that we know how to respond to them as opposed to react to them? We are going to talk, so I always kid, I'm a brain-based person. I believe in our understanding of the brain enriches our ability to create treatment interventions, but more importantly to me, when somebody understands the why, it helps to reduce the stigma and the shame associated with both suicidal tendencies or ideation or substance use, that when people start to understand, why do I keep doing this? How do I change this? And, you know, what is fundamentally wrong with me? When people understand the whys in regards to how their brain is impacted, I feel like it helps to relieve some of that anxiety and that shame where it starts to make sense. People ask me all the time, especially when I worked with adolescents, they would say they just need more self-esteem. They just need to understand themselves, you know, in a different way, and they need to see themselves the way other people see them. And I would say to families all the time, I can't provide self-esteem to somebody. That isn't possible. But competence builds confidence. And when somebody understands themselves where it makes sense, there's less of a judgment. So that's, to me, the profound necessity for really understanding how the brain is impacted. So I do that a lot with all of those that I'm serving. And then we're going to explore the application of some of the different motivational strategies that can enhance the treatment of somebody that has had experiences with trauma, substance use, and those symptoms of suicidality. When we start to look at the prevalence of trauma, the important piece is understanding that when we look at the CDC report, when we start to understand, and we'll talk a little bit about the ACE studies. I know I'm going to be doing another training in the future on complex trauma and fully kind of going into the experience. But when we start to look at 1 in 4 children experiences some sort of maltreatment, so whether that's physical, sexual, or emotional abuse, when we start to recognize the implications that it has in regards to those that we're serving, it becomes incredibly important for us to start taking into consideration how trauma not only impacts the person in regards to the way that they see themselves, the way that they see the world, and the way that they move through it, but in a very physiological way, somebody that's been impacted by trauma has been changed. So going through and recognizing our understanding of that allows for us to have a different approach and a different lens in regards to treating it. 1 in 4 women has experienced domestic violence, and as part of this, we're going to talk a little bit about partner violence in regards to suicidal statistics, and then the prevalence of PTSD. Sorry. Oh, I apologize. Excuse me. So I'm going to start with SAMHSA's, the key principles of trauma-informed approach, because I think that what it becomes is an important element to understanding. So what does it mean to be a trauma-informed organization? Again, having been in this field for over 27 years at this point, I can say that I've worked in various settings, and the difference when you start to move into a trauma-informed organization versus one that is not is pretty profound. You start to recognize the way that behaviors are understood and responded to. You start to look at the way that the organization is supporting a trauma-informed approach within the language that they're using within the organizational hierarchy, and most importantly, in the way that treatment is conducted. So when we look at these, and SAMHSA does a really good job of kind of identifying those assumptions and principles. So a program or organization or system that is trauma-informed realizes the widespread impact of trauma, and it understands the potential paths for recovery. So it recognizes the signs and the symptoms of trauma in your patients, in your family. So again, I am the Director of Family Services for RCA. And so that's a huge piece for me to make sure that if we are truly trauma-informed, that we are extending this out to the families who are also impacted. To our staff, recognizing again that we are managing, and we're going to talk a little bit about COVID as well in regards to trauma-informed care. So throughout this treatment or this training, I'm going to touch on how COVID has kind of impacted that in regards to those that we're serving, but also in regards to our staff who were once not considered a first responder or a frontline or an essential worker, but now are having to show up day to day. So I know, we have 8 inpatient facilities currently, and the staff had to change the way that they saw themselves. So trauma-informed recognizes that. And it responds. So the organization, if it is engaging in trauma-informed care, it responds by fully integrating the knowledge about trauma into your policies, into your procedures, and into your practices. And that it seeks to resist re-traumatization. So that's straight from SAMHSA, that's really what we're looking at, is seeking to reduce and resist re-traumatization. So when we start to look at, so what does this mean? These are the 6 principles. So we have safety throughout the organization. I think a lot of times people get caught in what safety is, meaning it's physical safety, but just as important is that it's psychological, social, and it's moral safety, that somebody feels safe even in the interpersonal reactions. And this becomes incredibly important because when I get to the symptoms, the shared symptoms between trauma and substance use, it's incredibly important for us to recognize how those symptoms can elicit a reaction from our staff as opposed to a response. So safety means the physical safety of the organization and the plant, and so that is without question. But when we're talking about psychological, social, and moral safety, it's that a patient can experience the symptoms of what brought them to treatment and that they will be safe enough to know. And I'll kind of interweave some experiences that I've had, but a perfect example of this is we had a few patients that were struggling in regards to some of the behaviors and some of the circumstances in treatment, and they presented it as very agitated. So they were looking for some resolutions. They were demanding to be heard in a way that others might have judged. And so when I sat with them to hear what the concerns were, that at the end of it, what they did is they said, "I'm sorry. I shouldn't have approached you in that regards." Creating safety is that what I was making very clear to them is that you do not owe me an apology, that you are allowed to be here in the experience of your symptoms, and that it's my job to be able to hold it. That's a really important piece in regards to clinical care, because what can happen is that if you are not trauma informed, if a patient gets loud or demanding or agitated, or that what we'll start to feel is this strong reaction and be like, who are you talking to like that? I'm not going to be, you can't speak to me that way. You're being disrespectful. But when we're looking at substance use treatment, when we're looking at that high level of acuity in the beginning, and when we get to the brain, we'll talk about it more, the reality is they are sitting in a fight or flight. And I'm not teaching them life lessons. I'm trying to help them to survive. So the way that they approach me becomes less relevant in the moment that I've identified that they're triggered. And that I know that if I can provide them safety, that they will get themselves re-regulated so that we can actually problem solve what their needs are. So again, that's a very important piece. I think we have a question. Are those groups or individuals, as I can imagine others' issues or behaviors observed could trigger others? Absolutely. I say this a lot when I talk about trauma is trauma triggers trauma. So when one person is impacted, it impacts the entire community. This is why I will say it is incredibly important for us that if we're really adhering to the 6 key principles of a trauma-informed approach, that we are paying attention to our staff as well as to the community. Because, and I say this all the time, if you are trauma-informed, then everybody in the facility, housekeeping, clinical, case management, reception, admissions, CEOs, everybody is the captain of the ship. Those that have experienced trauma have such a heightened level of sensitivity to the experiences of around them. It makes sense. They're trying to survive. So everybody in the facility is the captain. So if we are not able to create safety, and that's why I'm spending a whole lot of time on this safety, because I think without it, it's going to be difficult to do anything else. That this is a perfect example. So again, we have a first responders program, and right now there's a large amount of first responder that are experiencing various issues. And so they were all triggering each other. That one experience is very contagious to another person. So it becomes even more important that I don't react, that I create an atmosphere where there is safety as a priority, that then we can kind of recalibrate and move forward towards solution-based. So I'm not angry at the behaviors, and I'm not disappointed or frustrated, and I'm not stigmatizing them. I'm aware of them. I'm aware of the trauma responses that are occurring, and I'm going to create safety by hearing them and validating them so that I can continue to move through some of the other interventions. So hopefully that answered that question. That when we're talking about trustworthiness and transparency, transparency is an overwhelming necessity for somebody that's been impacted by trauma. So if you are not transparent, again, if we think about how trauma works, they are heightened in their ability to assess their environment to determine whether this is a safe environment for them. When we are incongruent as providers by saying, no, you didn't bother me, yes, when we are not transparent, it forces them to have to decide either their instincts are wrong or you're a liar. So transparency becomes incredibly important. Trustworthiness, doing what you say, and saying what you mean becomes incredibly important for those that have been impacted by trauma. I mean, for anybody in particular, but certainly those that have experienced trauma. Peer support, and again, mutual self-help are key vehicles to this. So making sure that you have communities where you can have peer leaders, where you're identifying that their own community is also going to be an additional resource. Collaborating and mutuality, so involving themselves in allowing for everybody to be a part of the healing of the community, patients, staff, empowerment, voice, and choice. And so this was an opportunity, again, as I just said, is that I came down to one of our neighborhoods to have a conversation so that they felt empowered, so that they felt they had a voice, and so that they understood the choices. Sometimes I can't change what our policies are, but I can certainly help them to understand why, because it's demonstrating the respect and dignity to which they deserve. They might not agree with it, but I need them to understand the why so that they don't think that this is punitive. And cultural, historical, and gender issues. So again, the organization actively moves past cultural stereotypes and biases. Hold on, looks like we have another question. I've seen that in CERT training where some were not trained to respond to persons with mental health issues and react, thus causing more of a reaction by the person that was in distress. Correct. The way that we respond is going to have a significant, it's going to have a significant consequence, either positive or negative. Now, that's not to say that, again, trauma can't supersede some of the regular behaviors. It's not to say that substance use, doesn't supersede some of the interactions at times. This is the nature of what we are dealing with. But our response to somebody that has been triggered is going to have a significant impact on their distress. So absolutely, has a huge role. When we understand trauma-informed and trauma-specific treatments, so trauma-informed is, as I had just discussed, an agency can be trauma-informed when they've adhered to those 6 key principles. When we're looking at and take into account the knowledge about trauma, its impact. So again, I can only speak for the agency that I currently work for. We became trauma-informed where we, looked at our wording in our policies and our procedures, but most importantly, in my opinion, and that's all that is in that second, we went to all of our sites and we trained every single person in our organization. We trained our recovery support specialists, our receptions, our admissions counselors, our therapists, our case managers, our housekeeping, our dietary, our maintenance, our facilities. We trained every single person, because if everybody knows and has some knowledge about trauma and its impact and interpersonal dynamics and the way that we can move to recovery, then every person should be aware that if we're truly trauma-informed, it appreciates that anybody can help somebody through a traumatic experience, that this doesn't rely solely on clinical interventions, that some of our best interventions could be from housekeeping. Some of our best interventions can be from our facilities gentlemen, from our housekeeping who offers to facilitate groups or sit with a patient who's demonstrating that they're struggling. That if we are truly trauma-informed, we are letting them know they are safe with all of us. That's the huge difference. When we start to look at trauma-specific services, Those are more to address the direct impact of trauma on somebody's life. So that would be geared more towards clinical. That would be DBT or CBT. Those are going to be more specific. Mindfulness, meditation, those are more specific, trauma-specific services.
We have a couple questions. If a client's behavior elicits a quick reaction in you, did you get that one?
I did not.
If a client's behavior elicits a quick reaction in you, how do you maintain transparency without making your reaction into your response? Do you disclose your experience in vivo?
Yes. So I think that's a wonderful question. Is, you know, and I use this phrase all the time, we're humans treating humans. So we can also have our own human experiences. But what I ask of all of our staff and what I encourage everybody to start to identify is our own need for, you know, and self-care has become a very trendy phrase. And so I use that very cautiously because it's not necessarily self-care. It's really, if I understand how physiology works, then I know I need to make sure that I'm putting in some deposits for myself. Because when a patient is engaging in something, when I find high reactivity from myself, it's an indication that either it's a trigger, and so adverse childhood experiences, I will go into it greater detail in one of the later trainings, but I always say patients have adverse childhood experiences, and so do staff. So sometimes when we elicit a reaction, it's more about that their trauma triggered our trauma, or it can also be that we're starting to have compassion fatigue, that we're starting to feel depleted, and so when a behavior is presented to us, we react very strongly because you have a reaction. If somebody's cursing me out, I do have a reaction. I'm a human treating humans. But I have to be able to kind of breathe myself through it to be present. I have to be aware enough that I can feel myself reacting so that I can appropriately respond. If you have engaged in a way that has demonstrated a reaction, then I do encourage the transparency. Sometimes I have said, sometimes it's enough to just say, wow, I can really feel how I'm reacting. And so I don't want you to have to take this. I don't want you to have to own this. That you're engaging in behaviors that are appropriate within what you're here to be working on. That's a key piece, right? We can't expect appropriate, quote unquote, appropriate behaviors when somebody is actively involved in getting treatment. That's why they're there for you. So when I talk about the shared symptoms, they're engaging in behaviors that are appropriate, indicating that they've had a history of either trauma and substance use or a combination. So when they engage in a behavior, I don't personalize it. I just see their symptoms being present. So yes, if you are noticing that you are reacting, it's a recognition. If it's in a group facilitation, I probably wouldn't do it there. You know, you might be able to acknowledge that you're experiencing something, but I would say I'm careful because you're also talking about others that have been impacted by trauma, and what can happen is that the group can try to protect you or save you, right? And so their stuff is going to start getting elicited, so I want to be careful that we're not asking patients to then take care of us. But in a session or a one-on-one that you might be able to say, I want to just acknowledge that I could feel that I was reacting. And so some of that is mine, that, you know, I'm aware of it, but I don't want you to have to own it. So I hope that makes sense, and I could circle back if it doesn't, because I have had examples of that in individual sessions.
Thank you. And we do have someone with a scenario that they had a client that had a physical abusive relationship with a husband number 2, and husband number 3 is a nice guy, puts the effects from husband number 2 has affected her present relationship. Yes. So she's trying to work through those issues.
Absolutely. So that is a wonderful example of how internal triggers can be manifested in many ways. So that would be somebody that if they were identifying that I would strongly encourage them to engage in couples therapy, because if they're trying to partner, they need to have some awareness and open dialogue of what are some of the triggers. So if number 2 was abusive, and the sound, so again, when we talk about the brain, hopefully this will help make a little bit more sense. if the sound of a man's voice elevated is a trigger, while she can rationally recognize that husband number 3 is not the perpetrator, the sound of a raised voice is an automatic trigger. So in couples therapy, it can be a recognition of both. So how do we in the beginning, because triggers just don't magically go away, how do we recognize in the beginning where he can become a part of the conversation and the solution so that he's aware, my loud voice when I yell, that's a trigger, and then they can work towards her getting to a place where she's okay hearing it. But sometimes what will happen is that they will address one side or the other, and then the undercurrent is going to continue to be perpetuated inside their marriage. So that's a really important piece, because otherwise the husband will say, why can't I mean, I'm just raising my voice. I'm not the one that's going to be abusing you. Like, you keep treating me like I was husband number 2. But all of that is not safe. So they perpetuate it. So couples therapy with somebody that is specialized in trauma could be really beneficial for them.
And Trish, can you explain what DBT and CBT are? That was a question.
Yes, so DBT is dialectical behavioral therapy. CBT is cognitive behavioral therapy. At the end of the training, I'll go into a little bit more detail about it. So CBT is obviously cognitive, so it's reassessing the thoughts, which is great. But when you're experiencing trauma, when you're pretty active in the early phases of recovery, and when you have suicidality, it becomes more important to start treating the body and the nervous system. And DBT does a little bit more of that. But we'll talk a little bit about that. I would love to hear your dialogue for juveniles in a detention center, because your words are powerful and many of them would benefit from it. Agreed. I did a lot of work with juveniles in the detention center. So that I would agree with. I think, again, you've got juveniles that when they can understand how and why they're behaving in ways, again, a very large percentage of my career was spent working with juveniles who were in and out of being incarcerated in the juvenile system, and their families. And so when they start to have an understanding of the why, because what a lot of people will say, and that can be juveniles or not, they'll say, this is just who I am. I'm just angry. I'm just aggressive. And so then what happens is it continues to perpetuate them feeling shamed and stigmatized when you start to just broaden it and say, so this is why you're there. This isn't who you are. This is who you become when you're triggered. So it's indicating that when you feel you're like that all the time, it's indicating that you are triggered frequently. And that's based in your experiences. That's your history coming back to you. So I want you to start becoming aware of the triggers. I don't want you to start owning this. This isn't a cape that you wear as, this is just who I am. It's just saying it's who you keep becoming. We all actually act in similar ways when we're triggered. So I would agree, juvenile justice system, all of that would be a wonderful opportunity to have those conversations. So that trauma-informed initiatives, it's learning to begin to respond to substance use through a trauma-informed lens. And so you've heard this said, instead of saying what happened to you or what did you do, that you start to say what happened to you, right? So I don't ask those questions out loud. You certainly can. But I'm always trying to pay attention. And when I train our staff, I'm always saying, whatever behavior you see, it has a purpose. So if you just shame them, the reality is that everybody is trying to survive. Everybody is just trying to get through the day. So whether it's suicidality, whether it's self-harm, whether it's substance use, people are just trying to get through. And what they have learned is how to survive. And the fact that they're sitting across from you, they have survived. So their brain is keeping track of things that they've done, and it starts making quick assessments that are not correct, but lend itself, because it was done in a very emotional reaction, lend itself to saying that is helping you survive. The reality is that if you were feeling an overwhelming sense of anxiety or PTSD or flashbacks, and you used the substance, it did relieve that. So your brain doesn't decide right or wrong, good or bad. It decides, did it work or not? And it did. For a lot of young adults and adolescents that I work with suicidality and self-harm, there's such significant shame and stigma around that. And for the most part, and that's why I'm so grateful that this training is being facilitated and that it was organized to do this, because suicidality is not just a taboo for those that are struggling with it. It's also one that providers are oftentimes afraid of as well. And so I always say, so then where are they supposed to go safely to talk about this? Because you can have a thought and not act. But when we react so strongly in so many ways, it shuts down the door, and people do this alone, and alone increases some of the vulnerabilities. So I'm grateful that this has been contacted. But again, for somebody that has suicidal ideation, for somebody that has self-harm, their brain is just saying some of this worked. Some of this is working. So being really on top of kind of having those conversations becomes incredibly essential. When we start to look at trauma and substance use, here's what we identify with some of the treatment outcomes. So again, we have trauma-specific programs in our facilities to address that, because we know that a large percentage of those that are coming into treatment have co-occurring trauma as well as substance use. And so again, you're going to continue to hear this. It's going to eventually get on your nerves, but I'm going to continue to say it, because the more that we can help somebody understand themselves, the less shame and stigma they will feel. That's incredibly important, because what shame does, so when we talk about the brain, and that's the next slide, what shame does is perpetually keeps you in the limbic system. It's perpetually keeping you in the emotional part of your brain that is preventing you from really fully accessing your coping skills to maintain and heal. So when we talk about PTSD and substance use disorders, it becomes incredibly important, because we're looking at people today that have had multiple reoccurrences of their disease, that have been in treatment 16, 17 times. And what I need them to see is that every time that they've entered into treatment is a sign of strength, not a sign of weakness. Because when somebody has been impacted, and I do use this phrase with my patients and families as well as my staff, some of our patients are 20 miles into the forest. And if you're 20 miles in, it's going to take you 20 miles to get out. Some are only 6. So what can happen is that if you're 20 miles into the forest, you might have walked 15 miles, but you're still not out of the forest. And so the person that was 6 or 4 miles in, they're already out of the forest. And so the person that was 20 miles in starts to feel hopeless. Nothing is ever going to change for me. I'm always going to be this person. And they can't recognize that they actually came 14 miles out of the forest. You are progressing, but you were 20 miles in. So how does somebody get 20 miles in? That's your trauma. That when you have childhood trauma, when you have been impacted by the adverse childhood experiences, when you have higher scores, you are further into the forest, which makes it harder for these things to respond as quickly. So I'm not trying to say, listen, if you have trauma, then you should, if you have trauma, then you should expect that you're going to continue to have a reoccurrence. But I'm also making sure that they understand it's not uncommon. And it doesn't mean that you're not progressing. It just means that you're continuing to move through. Looks like I have questions.
Yeah, we have one about clients who don't recognize trauma because it's always ever known. Is it harder to identify the triggers?
Yeah, so, and I will say, again, so that's a wonderful thing. I had the majority of them, and that's where, again, one of the trainings that we do when we talk about adverse childhood experiences, I worked for years with those that would have said, I don't have trauma. I work with first responders who will also say, I don't have trauma. This is my job. So I don't need them to own the definition for me to start identifying. Can we at least agree that these symptoms are more prevalent for you than others? So can we at least agree the physiological experiences are impacting you? So that I need them to recognize. If they don't want to say I've had PTSD, okay, I don't need you to own it. I just want to have a conversation about, and again, for a large portion of those that I've worked with, they would not have identified themselves as having PTSD or trauma. For one of my young men, when I met with him, he had aggravated assault charges against law enforcement, against teachers, and he was seeing me. And when we were doing some of these things, he was saying, I don't have any of this, Trish. But he literally witnessed a shooting. He had been shot himself. There was community violence. He was in an underserved community. He had experienced racism. You know, his father was incarcerated. So it is a cognitively normalized experience, but physiologically it still does the same thing. And so that's where we agreed. Can we agree that physiologically your body is going to be impacted because that's just how our bodies operate? That it doesn't feel like it's trauma for you, and that's okay, but your body is experienced. And how do I know? Because these symptoms are so prevalent for you. So I'm going to treat the symptoms. So hopefully that answered that piece. It looks like many substance abuse programs proclaim it is necessary for clients to avoid romantic, intimate relationships. Is this a position that you support? I don't know if I understand what that means. If you're asking if it's if we're suggesting that they don't get involved in an intimate relationship in the early phases of recovery. So if you're wanting to, if you sent that and you want clarification, just clarify what it is that you want me to answer, and I'll make sure that I answer it. To the other part of the question that you had asked, what if they don't know their triggers? I don't need them to know their triggers in the beginning. I need them to know that they were triggered. Because the reality, and I'm going to actually get to that now, and if you take one of my other trainings, you'll end up hearing this story again. But it's the best way that I can help with people to understand how triggers work. Because I think sometimes we think if they don't know the trigger, then they can't find recovery or healing. And that is not a message that I want patients to feel, because the reality is that most of their triggers are below their level of awareness. Is that this one? No. So I'm going to give you an example. And again, if you end up taking one of my other trainings, you're going to hear the same one. So I apologize in advance. But I have a 14-year-old daughter right now. And then I'm going to loop this into the brain development. I have a 14-year-old right now who, when she was probably about 7 or 8, she had asked me for a pair of high heels, of which I was super offended, because I am, while I look professional in that picture, on the weekend, I'm in a baseball hat, a pair of jeans, a sweatshirt. So she's asking for a pair of high heels. And I'm like, no, you're not getting a pair of high heels. You're a little girl. Stop it. A few days later, she asks me again for a pair of high heels, to which I am equally as offended. And I was like, no, that's ridiculous. Little girls don't need to wear high heels. You know, go outside. We're going to play. And a week later, she asks me again. And at that point, I stopped and I was like, why do you want a pair of high heels so badly? And what she said was, the sound of them makes me think of you when you're not around. So for her, the sound of my high heels brought to her, because the only time I wore high heels was when I went to work, when I wasn't home and I wasn't with her. So it elicited for her a feeling of contentment, of love, of security, right? Beautiful. Now, if I was an abusive mom, the sound of those high heels would have a very different experience. She would not have said anything to me because I would not have been a safe adult for her to say, Mom, when I hear those high heels, it makes me feel really threatened and scared because I'm afraid something bad's going to happen to me. And so instead, she would build it, and it would become a part of her story. But at a young age, she wouldn't have been able to integrate the experience, and she wouldn't have been able to associate the high heels. Her brain would have just made very quick assumptions and assessing the environment to say those high heels are going to be eliciting a negative reaction or a negative behavior for you. So if, 12 years later, she ends up in a treatment facility and she's standing in the lunch line and somebody walks past her with a pair of high heels, her brain is instantly triggered. She has no awareness of this trigger, but her brain has already assessed danger. And then when the person cuts her off in the lunch line, she's likely to initiate a fight. Staff is going to run over, what's going on? Why are you doing that? Why would you start a fight? And she's going to either say, I don't know, which we then as providers start to say, you know, well, what's wrong with you? You're just not being honest. You're not taking your recovery seriously, which is not true because they don't know. Or they're going to do what I always say, there's a fire burning when there's trauma and substance use and suicidality, and we get caught in the smoke. She's going to say, that girl cut me off, and who does she think she is? Right? And we're going to address the smoke, which isn't the real issue because it's not the first time somebody cut her off in line. And we've seen her be able to manage herself in other ways at different times. But it was that 5 minutes before, those high heels triggered her. And it elicited that reaction from her. So when somebody says they need to know the triggers, I don't care how good of a therapist you are. I think I'm a pretty good one. There's no way I would have said, you know what I wonder? I wonder if it's the sound of those high heels. I wonder if that's why you did this. And if I did, some amazing way that I identified that the high heels had something to do with it, and I said to her, I wonder if it's the high heels, she would have reacted of like, what do you think, I'm crazy? So I don't need them. So the reality, the moral of that story is we're not always going to know the high heel moment. But when you see somebody behave in a way that is uncharacteristic to the situation or supersedes the reaction, know they were triggered. And then we're going to treat the trigger. So I don't need them to know it was the high heels. I just need you. That might be long-term work, but I need them to just recognize when they felt triggered. So when we start to look at how the brain develops from the bottom up. At the bottom is that reptilian brain. It's the most primitive. It's responsible for kind of all of your instincts, eating, sleeping, pooping, right? So those are kind of the three that I always use in a treatment facility. And we know that it's being disrupted when we notice that their diets have changed, when their bowel systems have changed and they're not able to. We notice this because their sleeping has been impacted. They can't sleep anymore because there's such high levels of adrenaline and cortisol in their system that they can't go to sleep. Which again, when I explain that, I'm like, well, of course you can't. If your body thinks you're under pressure or that there's a stress, your body is trying to keep you alive. You shouldn't be sleepy. If you think you're about to get, eaten by a bear, you shouldn't be sleepy. So your body's doing what it thinks it's supposed to do by keeping you awake. It's just that it doesn't know the difference between real and perceived. That's a huge distinction in trauma. Real, perceived, because the brain's eliciting the same reactions to both, right? So that goes back to the husband, real and perceived. It was once real, but the brain reacts in perceived threat the same way it did in the real threat. That's how a brain operates when it's been impacted by trauma. So as the brain continues to develop, it goes to the brain or the limbic system. The limbic system is, and this is where it overlaps within suicidality and substance use, the limbic system is the emotional part of the brain. It's where your fear response system is. It's where the amygdala is, which is the brain's part, where it is, I always say it's like the smoke detector of your brain. So it's paying attention to the environment. And the more you've been impacted by trauma, the bigger that smoke detector gets, figuratively, not literally, that it gets more and more sensitive. And that's where you see people that start to kind of react very strongly throughout the entirety of the day. The limbic system is also where the pleasure reward center is. And so if you have a dopamine deficiency, quote unquote, not legitimately, but if you've experienced a lot of trauma, there's less dopamine that's being produced inside your brain. And so you need more of something to get the same kind of like calming rest. Serotonin is changed inside that, the brain. And so when you use a substance, the limbic system, which is survival, the limbic system is not rational. it is survival, and it works much faster than the cortex. So it would be the difference of a text message versus like old school mail, postal mail. So the limbic system makes very quick assessments and judgments. This is where when people say people, places, and things, it's because the limbic system in those experiences has paid attention to things that you weren't even aware it was paying attention to. Then when you use a substance and you're still here and it works, your brain says, because another part of that is the hippocampus, which retains memory and associations, it says that worked. So when we talk about cravings and triggers and stuff like that and urges, that's really on a physiological basis, that's what that means. It means that your brain is like, oh, that worked. You were feeling this way, you used a substance that worked. This is also where self-harm. I work with so many kids and young adults who engage in self-harm. So much shame and stigma associated with it. But it's the same thing. That when they engage in it, it physiologically releases neurochemicals that allow for them to be okay. And so their brain says, again, keep in mind, that limbic system doesn't decide good or bad, right or wrong. It decides, did it or did it not work? So self-harm is sitting in the limbic system. I had a young girl that was engaged in self-harm and suicidality for years. And when we started talking about this, I said, I need you to understand that your brain is trying to keep you okay. It's trying to do the best it can by you. And so we can work towards finding a different path. We can create options for you, but I don't want you to be angry that this is because she wanted the thoughts to be gone. I just don't want to think that way. And I'm like, I can't control that. You can't control that because your brain is paying attention to things that we didn't even know it was paying attention to. But if you're aware of it, we can create options for you because the only one your brain knows right now is either the suicide attempt or the self-harm. So let's create options. But I don't need you to be angry at it. I need you to recognize it as your body trying to do what's best for you. I need her to see that this was a strength, not a weakness. It's what it's doing its best it can. We just have to create other options. So that's the limbic system. For most of those that we are treating, they are predominantly sitting in the limbic system. It is the fear or fight. It is the dopamine reward center. It is the hippocampus that's retaining the memories. It's the amygdala with the very, very sensitized smoke detector. That's what that is. At the very top of the brain, in the way that it develops, is the cortex. This is what makes us human. It is thought-provoking. It is the humanity of who we are. It knows the consequences. It weighs your choices. It knows what recovery is. It understands what recovery is. All of these amazing things is the cortex. But for somebody that's been significantly impacted by trauma, the limbic system, again, that is an immediate. It is survival. The bigger the trigger, the less the cortex is even able to be utilized. The limbic system almost exclusively shuts it down. And again, I always think if you were in the woods and a bear was about to eat you, the limbic system is going to react immediately. It's going to tell you what you're doing. You're going to either run, you're going to, freeze, or you're going to fight. You do not need to pay attention to those thoughts. It's automatic. The cortex would be like, I don't know, it looks like it's a fat bear. I bet you could outrun it. The cortex would try to start figuring out and problem solving this, but it could kill you. So the limbic system literally shuts it down. So when you have somebody that's saying, I don't know why I keep doing this. I don't know why I acted that way. I don't know why I keep having these thoughts. It's an indication that their cortex is getting shut down and their triggers are higher. So I don't need them to know the triggers. I just need them to be aware when you're having those thoughts, you're in the limbic system. We're going to give you skills to calm the limbic system down. That's where the treatment starts. That's where when we get to like regulation, motivational enhancement, when we talk about those things, it's to address the limbic system to calm it, because if the limbic system is highly aroused, the cortex can't be activated anyway. Hopefully this is making sense. I am looking to see.
Yeah, we have lots of questions.
Yes.
How do you recommend staff respond specifically to those presenting as disrespectful and aggressive in inpatient settings?
Yeah, so, and that I think is a big thing, particularly in an inpatient, because if they're an inpatient, it's an indication that they are at a high level of acuity. So when you have an inpatient, your patients are living in the limbic system, right? So that's the starting point, is I would not expect somebody coming into an inpatient to be sitting in their cortex, and to being respectful, to be, appropriate. Those are cortex level skills. If you're about to get killed by a bear, pleasantries are irrelevant. They are not survival skills. So helping staff to recognize, so how would I address it? And again, we do. We are an inpatient facility. We see these behaviors all the time. That when we are not reacting to them, they don't elevate, and that there's skills that you can engage with somebody that will allow them to start decompressing. So again, when I met with all those first responders who were highly agitated and very activated, my presence and the calm kind of way that I was addressing some of their concerns helped where my behavior became more contagious. And I say this all the time. When somebody, I always say, are you the ones, pay attention to who patients feel they need to say they're sorry to, because patients don't owe anybody an apology. That's not what we're here for. But patients inherently want to be heard, and they don't want to lose somebody that they feel is on their side. So they always come back. When they engage in a behavior, they don't want somebody to have seen that as who they are. So they oftentimes will come back and say, I'm sorry. So when somebody is disrespectful, it is a matter of staying calm as the staff and then bringing them somewhere else. I know we take things personally when we react. So if somebody's cursing me out, it's actually triggering me because I'm trying to teach them lessons. And I always say, we're not teaching people life lessons, not in early inpatient. We're teaching them how to survive, because the life lessons and how to be respectful, those are long-term goals. Our patients are just trying to survive. So I'm going to bring them out. I'm going to help them to calm their nervous system. And if they decide to say they're sorry, that's on them. Oftentimes they do, because nobody's trying to act that way all the time. But they're demonstrating that they've been triggered. So if we see it as a trigger, we tend to personalize it less. And again, I'm aware, like sometimes people are like, you don't know what it's like. I'm like, first of all, I'm in an inpatient. But I worked in a long-term residential for adolescents. They were constantly sitting in there. So I know that it can work, but I know that it requires, and that's what trauma-informed is, it requires a lot of attentiveness to staff. It requires a lot of education and support for our staff, because their experiences are also valid, but they have to come to the door knowing that the vulnerability and acuity of those that they're serving has to come first.
And what kind of suggestions do you have for criminal thinking offenders and how resistance can be addressed?
What does that mean? If criminal...
So we can have that person give some more
clarify?
information.
Okay.
Yeah. And how do you use your own trauma in working with people?
So if you've experienced your own, that's a supervision and a private therapist, right? So you need to, if you've experienced your own and you're aware that it's bringing you into, that it's being triggered for you, those are moments to utilize supervision and also an identification that you could also benefit from additional support. That there's no shame in that, right? That there's a lot of people that have overcome their own obstacles in life and barriers and trauma, and then become part of the helpers. But if you're noticing that you are being triggered by others' triggers, then that's an opportunity to be like, okay, so I gotta take care of myself, because I also am allowed the dignity and respect of making sure that I nurture myself and take care of myself. Because we are working with people that have a very vulnerable population that are constantly triggered. And we want to make sure we don't get caught in theirs. I did see one of the things. So at what point does the behavior stop being excused because of trauma? if the person is not taking an active role in services or does not seem to make progress or is stuck, or choosing to be or is comfortable in the victim role rather than wanting to learn and manage out of the survival. So I will say, so sometimes the stuck is freeze. So when somebody gets stuck, they're likely demonstrating. So I will say this, and that's a huge question that comes up a lot, is that are we enabling behaviors? So in no uncertain terms are we enabling. If you're using substances, there's consequences to it. So this isn't about enabling behaviors or condoning behaviors, but we are treatment providers. So we're helping them to identify, so what do you want different? This is different than if this is a personal relationship. So sometimes those get blended. Sometimes people will say, in my personal relationship, at one point, are they supposed to like recognize you got to let go of the trauma, right? So I could see that husband saying that about that wife. Personal relationships, this is very different because you have a personal relationship. And so that's where therapy, I think, would be very beneficial for couples. If one couple, one member had experienced trauma so that they can work through this. But in treatment, I'm not excusing. So, you know, one of the young men has an aggravated assault charge. I'm not condoning the behavior and I'm not enabling the behavior. I'm not trying to get him out of the consequences, but I'm trying to figure out, so what do you need to do differently in order for this to not continue? How are you going to understand how your brain operates, that if this is not what you want, and that's really where the motivational enhancement comes in, because I'm going to say, you tell me, what is it that you want? Are you okay getting incarcerated? Are you okay using substances? And if they say, no, I want it different, then I'm like, so then we got to look at how we're going to do it. So that motivational enhancement is that they do get to decide. They can decide, I would rather take the risks and I'm going to keep doing this because I don't want to feel the way that I did. So I'm going to continue to use. So I'm not getting them out of feeling like a victim, or I'm not perpetuating their trauma. I'm just saying, these are the experiences. This is what we understand in regards to it so that we can treat it differently. So having said that, if you have any additional questions, it's 11:02. We will take a 5-minute break, and then we will come back for the rest. So if there's any other questions, please feel free to let me know, and I will answer them when we come back. So we'll take a 5-minute break. We'll come back at 11:07. Okay, welcome back, everybody. It is 11:07 now.
We have lots of questions for you.
All right.
One of them is, how do you teach or help someone with severe anxiety?
So we'll get to that a little bit when we do the treatments. But again, I would say, my approach is going to kind of remain similar no matter what they have. I'm going to help them to understand the why. So how does anxiety work? What does it look like? How did it start? And what in my life continues to exacerbate it? And then I'm going to start highlighting skills. There's a lot of people that feel like they need it to just go away, or that there's going to be something, a quick fix. And so I like to help people to understand, like, listen, we're going to just start building some skills, right? That your body is doing the best that it can. It's trying to figure out a way in which it can help you. And so we need to start arming it with some other skills, because if it doesn't have them, then it's going to resort back to what it already knows. And anxiety is one of those that people perpetuate and continue in the same behaviors. That's kind of where PTSD is, as a sense of trying to relieve it. So in a very simple way of addressing that, helping them to understand why the anxiety exists, helping them how anxiety exists, and then building skills that start to address that limbic system response.
Thank you. And for someone new to the field, what do you consider the standard frequency for utilizing a private therapist for one's own trauma?
I mean, I think it's one of the greatest gifts that you can give to yourself and to the population that you're trying to serve. So if you're still working through it, if you're having a question of like, do I need to see somebody? To me, it's like asking if you need to be seen, and again, I don't mean to simplify this, but it's one of those questions, like if I'm like, do I need to see the dentist for this tooth? It means I probably already do. It means that I'm already having some issues with my teeth that would indicate that I probably need to see the dentist. So if you're struggling with it, I think it's really, again, it's one of the greatest gifts you can give to yourself. And I think there's a lot of people, and I've supervised a lot of people that have been able to identify the work is so both demanding and rewarding, but it does take tolls on people. And that there's, same as with those that we're serving, we all have our own vulnerabilities that can increase or decrease the impact of somebody else's life on our own. So sometimes when you're working with a high level of acuity or those that have been impacted by trauma with significance, sometimes having somebody as a therapist is a great resource for the therapist or somebody in the field, because it allows for them a safe place to continue to voice what they're experiencing. So I'm a big fan of, anybody accessing therapy while they are in the profession, particularly if they're kind of wondering if they need it.
Thank you, Trish. And we've had a lot of great comments on how great of a job you're doing.
Oh, well, that's nice.
And any thoughts on victims who become perpetrators and how to address the trauma they had and that they are causing?
So that's a whole different training. Because most perpetrators are obviously the victims at one point, and it's the way that their brain has compartmentalized the experience. So there's no short answer for that one, because you're really looking at a very different psychology behind working with a perpetrator versus working with somebody that's experiencing. It's kind of like an internal experience versus an external, similar to like where we see aggression and violence. People either internalize their experience, and we see higher rates of depression and suicidality and self-harm, or they externalize their experiences, and we see a lot more aggravated assaults, aggression, and violence. So the experiences are coming from a similar place where their brain is having to interpret how to make sense of the experiences, these profoundly impacting traumatic experiences. One is externalizing it and one is internalizing it. So there's no simple way for me to answer that. That would quite honestly be an entire training. Sorry about that.
We have time for one more question.
Okay, sure.
What advice would you give to clients that are also high-performing perfectionists that use behaviors to minimize effectively dealing with trauma, PTSD symptoms? The result so far has been intermittent crashes in mood or explosive anger, and the cycle continues. My fear is that during any of the crashes, suicidality is considerably heightened.
Sure. So I think, again, these are, recovery, as I said, is sometimes for us as therapists, we also need to make sure that we're reminding ourselves that if somebody's 20 miles in the forest, it's still going to take them 20 miles to get out, because sometimes we have higher expectations of the progressiveness. When you're working with trauma, it's slow. And the more somebody's been impacted by trauma, the slower the work, because the establishment of safety becomes paramount. So having somebody that's a perfectionist, the motivational enhancement that we kind of will, get to is going back to denial is a part of, it's one of the symptoms of substance use. It's one of the symptoms of trauma. So I'm never bothered by it. When somebody minimizes, and I'm aware in the substance use world especially, people are very triggered by somebody minimizing their experiences or, not telling you the truth. And I'm like, those are symptoms. So I'm not bothered by that. That's where the motivational enhancement is, that you can say, so what is it that you want? So the perfectionism, so I can call out a behavior, but again, the way that I perceive things is behaviors exist for a reason. And if we eliminate a behavior before they have either figured out the reason it existed or found an alternative way to respond, they're automatically going to come back to that behavior, because survival will always supersede rational thought. So when we're rationally being like, you need to do X, Y, and Z, because that will eliminate some of these things, rationality will never win when somebody gets triggered in an emotional experience. So when it perpetuates, or when I notice a behavior that keeps coming back, it normally is where I pay attention and I go, oh, there's a reason. This one's protecting something. So I can pull back a little bit and say, I'm noticing that these same things. So if it's, hyper-focused on type A personality, and again, some of that might be this combination of trauma and OCD, or a type A personality. So I'm also not a fan of trying to get somebody to fit a mold. If somebody's a type A, that's personality. People are born type A's and people are born type B's, just like some people are born introverts and some people are born extroverts. Everybody tries to fix that. I worked with a woman that was an introvert for years, and she was saying her therapist kept making her go and do all these social things. You're an introvert, so it's okay to be an introvert. You're allowed. You're allowed to be a type A. So it's trying to tease out, how do you continue to manage your type A? Because when you try to get a type A personality to act like a type B, you're actually increasing their anxiety. So what is it that you don't want? And let's start having a conversation about how this is getting in your way. That's the motivational enhancement. What is it that you're seeing that's getting to be troublesome? And on some level, and that's where the full assessment comes in, if I'm identifying the child that was also type A, and I can hear the language of like trauma as it's coming in there, I'm now having to balance both. But I'm not trying to get personality to be changed. I'm trying to get what it is that they're struggling with. And if a type A personality is saying, I wish that I wasn't a type A, that's like me saying, I wish I didn't have diabetes. Some things we got to learn to accept. But there's things that we could do within that personality. So hopefully that helped to do that. But we do tend to have a set point that we think all people should kind of fall within. But the reality is personalities become incredibly important. When I do lectures and conferences on self-care and wellness, that's one of the first things I always say. Everybody's like, you got to do yoga, you got to do these things. And I'm like, that doesn't take into account personality. So people need to attend to who they actually are to then strengthen who they want to be, as opposed to you telling me I need to do yoga. I don't want to do yoga. It's not my personality. Yoga actually stresses me out. I prefer to go hiking. Oh, so you have to match the personalities with what it is that you're trying to work with. The brain's alert system. Was there any other questions?
Yes, there's several. I just was trying to be cognizant of your time. I'd like to know some adolescent-friendly approaches to help educate on personal trauma. I have had several that I can understand their ACEs, but they haven't reached that executive understanding. How can I engage them initially? Activities, videos, what resources?
So for adolescents, again, because they have their own ways of protecting, and because, again, adolescents, particularly if they are connected to their families, they will also minimize their experiences because they don't want to cause pain to their families. So, you know, that kind of triangle that I showed you, I actually show to everybody. I mean, I've worked with kids as young as 11 and folks as old as 82. I use the same thing. I'm literally teaching everybody to understand how their brain works. Because particularly adolescents, at some points, they're not ready to disclose or to talk about their trauma. And I'm a fan of saying, I need you to have skills before you do. I need you to know that you can get yourself regulated before we do a narrative. And I always equate it, you know, with, and I just did this with our first responders. In a moment that we think we're about to have this cathartic moment, right? I'm going to get this off my chest. I said, have you ever said something to somebody in the heated, you know, in a heated argument, and you felt in that moment it was going to feel so good, and you said things, and they might have been mean and hurtful, and then an hour later, what's happening? And everybody was able to realize they couldn't stop thinking about what they said. Right? I shouldn't have said that. It was so stupid. I shouldn't have said that much about myself. I shouldn't have disclosed that. I shouldn't have. Right? The cognitive piece starts judging what the limbic system did, and so for trauma, adolescent or otherwise, I'm a bigger fan of saying, listen, I'm going to try and contain it for you a little bit because I need you to be able to have the skills. So when it repeats itself, when you revisit whatever the narrative is that you just shared, you have the skills that whatever your go-to coping skill is. For us in my world, it's substances. It could be violence, it could be aggression. Whatever your coping skill that they learn, self-harm is a huge one. I need you to have options first. So while it might feel like you want to get rid of this internally, I need you to have the skills so when it comes back to visit you later, that you have the ability to manage those thoughts then, when you're not with me. Because I can contain it in my session, but you have to be able to contain it when you're not with me. So that's kind of how I reorganize it. So I'm still telling them and teaching people about the brain. I'm just doing it in a way that helps them to understand, so why do I think that way? Why do I keep wanting to do these things? Why do I self-harm? Why do I use substances? So hopefully that helps. Any others? Nope. Okay. So when we're looking at it, I will say, so in respect to the timing that we have, there's going to be some slides that, again, I don't necessarily, because it's a presentation, you have a very linear process of creating the PowerPoints, but I've kind of overlapped in some areas. So if you see me skip a slide, I have likely covered it in some capacity, just in the way that we've had these conversations, but feel free to reach out with any additional questions. But just to be respectful to everybody's time and to make sure that we are finished right about 11:55, I might just glance over or skip over a couple of the slides. The brain's alert system. So again, this is what we had, I had kind of mentioned when we were talking about the way that the brain responds, is that fear's response system is this hypothalamic pituitary adrenal axis. Super, super long word. HPA is a much easier way of doing it. And so when this happens, and this is where, again, I don't use that word, right? So I don't tell a lot of the patients about the hypothalamic pituitary adrenal axis, but I do talk to them about their fear response, that if your brain perceives a threat, and again, that amygdala is determining all the time a threat. This is also why transparency is really important, because if the amygdala perceives a threat, then it is going to release this fear response system. It's going to flood the brain with cortisol and adrenaline. This is why you can't sleep, because if you're about to have a threat happening to you, you don't want to be sleepy. And so it impacts three main regions of the brain. The nucleus accumbens, which is where the dopamine reward center is. So when I had said kind of a dopamine deficiency, this is where it is impacted. There's less dopamine that's produced. so they do not get the same effects that others might get if they were to have a cupcake or if they were to do something pleasurable. This is why their brain responds differently to a substance. The amygdala, which is the fear response system, that's the smoke detector. So the bigger the smoke detector, again, figuratively, not literally, the more sensitive, maybe that's a better word, the more sensitized the amygdala is. It's the equivalency of like a smoke detector that I have in my house, where if my daughters take a very hot shower, it goes off. But it's not a crisis. It's not smoke, it's just steam. So I always kind of describe to a patient, listen, your smoke detector isn't wrong. So again, if we refer back to that husband number 2 versus number 3, your brain is not wrong. The smoke detector is not wrong. Something did change in the environment that elicited a response, but it wasn't a crisis. So helping your patients to start to determine the difference between steam and smoke. That's kind of the work that in a very, kind of a little bit of a nutshell, I'm always saying we're trying to figure out the difference between steam and smoke because your brain is responding to all as if they're all smoke. But the steam from a shower is not smoke. I don't need a fire department to come. It was just steam. But it wasn't wrong that there was a change in the environment. There was. There was a lot more dew and humidity inside the environment. So it's not that they were wrong. And that I want them to know too. This isn't that your brain is misfiring. It just doesn't know the difference between the steam and the smoke yet. That's what treatment is. And then the cortex. So again, if you are predominantly sitting in the limbic system, the cortex is being utilized a lot less. That's where recovery happens. So when we get frustrated at somebody because they continue to engage in behaviors that don't make sense to us, it's because they're not able to activate their cortex to the level that they need to. That means that we have to do the work kind of in that limbic system. When we talk about the shared symptoms of suicidality and trauma, as I continue to mention, these are the shared symptoms. So this is incredibly important for me to know that our patients are aware of, but more importantly, I need staff to know this. So when our patients describe very low frustration tolerance, when they get angry because you ended group early or you were late to group or they didn't get a smoke break, expect that. That's on us because they're coming in so profoundly impacted in their limbic system that these are symptoms. The thing about symptoms is you don't get to choose them. You get diagnosed based on your symptoms. So when we think about things like depression, and I always ask our staff, if you saw somebody that was crying or sitting and they were isolating, what would you do? And staff overwhelmingly is like, we would go over to them, we would see how they are, we would get them a glass of water, we would ask what they needed. And I'm like, and how does that normally work? And they were like, in the moment, it works well. They're grateful that we did that. And I'm like, but when they act like this, and they curse you out, which is poor impulse control, and they tend to act like rash decisions. So they're like, screw you, I'm leaving treatment. You don't know what you're saying, all these things. When they're denying that they have any problem, I don't have a substance use disorder. When they engage in suicidality or self-harm, what typically happens is we react. But then that's on us because their symptoms are their symptoms. They don't get to control if they have the symptoms of depression or the symptoms of trauma. Those are their symptoms. So anytime, if we can look at this, then we can actually create a different lens in how we see them. When somebody curses me out, then I go, oh gosh, that's one of their symptoms. I would treat it no differently than if I saw someone crying. It's just that we are more comfortable with somebody crying than cursing us out. But it's a symptom. I did have one staff member ask, like, so what if this person's really a jerk? And I go, well, then I'm going to use them as a one-off, and I'm still going to argue that they deserve recovery and healing. So if somebody's, everybody's worried about the people that are like getting away with it. And I'm like, if somebody's not able to have appropriate manners and they don't ever change, I'm really still saying they still deserve life and recovery and healing from trauma or, anything else. But the reality is that I'm going to look at these behaviors as a trigger. I'm going to look at these behaviors. And the more that I see these things in somebody, the more I know that they've been impacted by trauma. So when you see somebody that behaves like this 90% of the day, they're so far down into their limbic system that you're not going to be able to get them to be rational. And that's where you see somebody behave differently from 1 minute to another. So this, I'm going to skip because it's just the program organization. We've talked a lot about this. So I'm going to skip that one. Is there a question?
Yeah, what type of therapist does someone need to ask for if they want someone who is knowledgeable about and works on the concepts that you were discussing today?
So they should ask for somebody that's got, that's either certified or is trauma competent. So if you were asking for somebody that had that kind of competency within trauma or has worked within the realm of trauma therapy, therapists would be able to identify that. Some of them are certified, and you can ask if they have a certification. If not, sometimes people are not certified in trauma, but they have trauma competency. They've done a lot of trainings and have participated.
And how do you work around policies and procedures that require group attendance, individual sessions, or any other requirements that may not be a good fit for a client due to their personality and or preference?
So the individual sessions, again, you know, sometimes this becomes kind of part of the managed care, is that particularly if you're in an inpatient for mental health or substance use, participation needs to be done. But I will say that's where you come back to the motivational enhancement. So we've had that plenty of times, that patients refusing. Sometimes it's a freeze response. And so we know that we need to, is that it's in that moment that you're able to have a person, and it can be housekeeping, it can be facilities, it can be a therapist, it can be a recovery support specialist, whoever that patient feels connected to, help to identify, so what's the barrier? Like what's the holdup? I mean, we've had a lot of young adults that they were not coming to group, but when I would work with the primary therapist who specializes in young adults, and I'm like, do you know why he's not? And she was like, no. And I'm like, can you find that out? Can you ask him why he's not going? Is he anxious? Is it uncomfortable for him to be in group? Right, that it's anxiety and we need to help manage that. Is he just refusing, right? And then we know that maybe post-acute withdrawal is still there, or maybe it's, again, a trauma symptom. Or, and what she found out was he couldn't sit, so he was embarrassed. He has incredible ADHD, he always has, and now he's experienced post-acute withdrawal. He physically couldn't sit in the group for an hour and he was embarrassed. So then we were able to actually problem solve that. So I think sometimes what happens is we get lost because we're treating everybody the same. And we're like, you have to go to group. And if you don't go to group, then you just can't get, you know, you're not able to stay in treatment, or you're being resistant. But here was a kid that people thought he was being resistant, and he wasn't. He was embarrassed. So we actually ended up she started groups where everybody stood up, everybody stretched. He had a fidget. So he was given a fidget that he could do. He was given permission, and she announced it to everyone to not shame him. Listen, if anybody's having a hard time sitting still, it can be difficult to sit for an hour. Feel free to stand up and walk around the room. And then she said, is anybody going to be distracted by that? Because we want to be respectful to everybody's experience, and some people have a hard time sitting. So are we all good with that? They all said, yep. And then he was able to participate in group because he did want recovery. She asked him, do you want to be sober? And he was like, yes. So she said, so what's the problem? Like, how are you not getting to group? That's what it was. So having the right conversations to address the right personality, it's not all the same. If it's anxiety, then it's how do we help you feel safe? What do we need to do if you're experiencing anxiety in those moments? Do we have you sit by the door? Would it be helpful if you sat next to somebody that you had a peer relationship with? Who are you closest with? This person. How about you sit next to them? And what would you need to do? So we're going to also give you fidgets. If you start to feel highly anxious, what are some of your skills? What do we need to do? And then they identified it. So they were pre-problem solving, because in the moment, he can't. So that would be what I would say in regards to that. This we talked a little bit about, so I'm going to skip over it because it's 11:30, and I want to make sure I'm getting to the suicidality pieces as well as the interventions. Any additional questions?
Well, we did have a question about gossiping and rehabs for women. Is this part of a trauma response? They say they can't stop gossiping.
It is a way. So it's an interesting thing, because in adolescence, part of what is developmentally normalized is for women in particular, they become relationally aggressive. So as their bodies are physiologically changing, you know, it was one of those things, women would become relationally aggressive and men became physically aggressive. So when you think of your high school days, maybe late middle school, high school days, those patterns were not atypical. Again, just based on the physiological, the normal developmental tasks of an adolescent. When you start to see, you know, one of the symptoms that I had shared is this idea of trauma bonding. The fear of isolating. So sometimes those behaviors stuck, right? So depending on where, you know, the behaviors were associated, depending on what was going on in adolescence, behaviors that work are reinforced. So you see sometimes behaviors continue as people get older. So even though they're no longer an adolescent, they still engage in adolescent behaviors. Gossiping, for lack of a better term, is also a way to feel connected. So a lot of times people engage in those conversations because they feel connected to another person. So it's a conversation, you know, in those respects. And I just did a group with our female population in regards to that, of kind of getting them to recognize the power of when women support one another, but also recognizing that these are incredibly difficult times. Some of the most difficult things that they've ever had to do are in the moments of being in treatment. And so helping them to normalize how everybody started to feel isolated. People are feeling lonely. And that when we have that experience, we're looking for a way to connect. So how do we connect? Because when we do that behind somebody's back, it's fair to assume that it can start to compromise their own recovery because they're perpetuating old behaviors, but also the recovery of somebody else that might be vulnerable. And so I think sometimes it's addressing behaviors in a way that doesn't penalize, punish, or shame. When we do these things, it's because we're trying to stay connected to people. So are there other ways that we can stay connected to our community that don't hurt other people? There's going to be plenty of people in the treatment facility you don't like. Absolutely. But you have learned a way to stay connected where it benefits your experience, but is there a way for us to learn a new behavior where it doesn't come at the detriment of anybody else? So it's like an N plus. How about when they're physically threatening or dangerous? Then obviously that would need to be more addressed. Again, trauma triggers trauma. And so for a lot of the young men, they were very physically aggressive. When you see the behaviors, it's an opportunity to kind of discuss with them what's going on. I'm noticing this change and I'm noticing some of the behaviors. I can't forfeit the safety of a community for one person. So if I'm really concerned about the community in regards to a person's traumatic symptoms, then I'm not punishing them by saying this might not be the best place. I might be recommending that they transfer. And again, unfortunately, we've had to do that somebody's trauma responses were so significant that they couldn't get them contained. And what happens is that once they start to engage in that, the community is then very reactive to them. And oftentimes, and for those of you in inpatient, you'll see it, oftentimes it almost becomes reciprocal. So they are eliciting some of those stronger reactions out of that one person, and that one person is eliciting pretty strong reactions out of the community. So if it is something that becomes significantly detrimental to the community, you cannot sacrifice an entire community for one. But I don't need to shame somebody for the behaviors. I think that was the only question. So I'm going to move on. When we look at, again, suicidality with increased vulnerabilities, and some of this I'm not going to necessarily read because you guys can access it as well, but I just want to highlight some of it. Alcohol and substance use have been found to be strongly related. So why this is important to me, and again, you can read the rest of it. So I had mentioned that I work with a young adult who has active suicidality. We have had very open dialogue because, again, providers are oftentimes very afraid of talking about suicide and become very reactionary. And so I'm not minimizing it, but I also want people to know that we are safe to be able to have these conversations, but it does require a lot of our own work. So if she's saying, I don't want to live anymore, I want to die, I need her to know she can tell me this and that I'm not automatically going to 302 her, that we're going to have a conversation. So she knows I'm going to tell her when I'm concerned. that this is an identification that you are experiencing and when your thoughts are ahead of you. I want you to also learn that you can trust yourself, that you can have a thought and not act on it. So I want you to be aware of that. So we're going to have an open dialogue on whether or not I think you need to be placed at a higher level of care. So she becomes a part of it. That's that mutuality. That's the collaboration. Now, this is somebody that's in an outpatient. When I'm talking about that versus inpatient, and inpatient is a little bit different, is the alcohol and substance use. She also knows that if you're having these suicidal thoughts and you are drinking alcohol, I am more likely to think that you need to go into for an intervention. So whether you get 302'd, whether we put you, in a hospital setting, but alcohol increases the likelihood of you attempting. That's just how it works. That's what alcohol, it's a depressant on your nervous system. It increases the thoughts of wanting to commit suicide, and we do see links where people are more likely to try. So that she knows, because I need her to be aware of it. She's telling me she does not want to die, but she has these racing thoughts. I need her to know the same information that I know. So again, information you should know, which is why these conversations should be had. Suicide is the leading cause of death among persons who misuse substances. Persons treated with alcohol use dependence are 10 times greater risk of suicide than the general population, and those who inject are 4 times more likely or more at risk. Some of the things that put a person at risk, in treatment at risk, because they seek help when their use is already out of control. So that puts them at risk because in order to go into an inpatient, they are identifying that they were at their most vulnerable. That's how you get there. Most people don't come into an inpatient facility when things are going well. So you need to, again, this will follow suit with the assessment processes. You have to make sure that you're doing an appropriate assessment, because them coming in the door is indicating that things were incredibly unmanageable prior to the admission. Other life factors likely to be out of control, so family, work, all of these once protective factors are now risk factors, because families are angry and scared because they are potentially losing their jobs. All of these things put them at greater risk at that initial stage of going into treatment. The treatment-specific risk factors, so treatment transition, so going from an inpatient to an outpatient, partial hospitalization to intensive outpatient, all of these start to also increase because of the safety factor, because they are having to transition into something new, which is triggering for trauma. Assessing for the history of suicide ideation and attempts. Expectations, so a lot of times people will already start worrying about the relapse, so having those conversations, and the experience of acute life stressors. Again, that family, jobs, furloughs, all of these other indications. So I will say, so it's 11:40. I'm going to spend a little bit of time on this, but I did put this, and I will say I intentionally did this, these are a little bit heavier in the PowerPoint because it's going to give you the statistics that I think are relevant. So I don't need to necessarily read these to you, because I think it will, you'll be able to utilize this as just making sure. So why are we saying that this is a risk factor? Why are we saying substance use is a risk factor for suicidality? Is that here's some of the information. Again, it increases the risk if they're abusing substances. There's some substances that increase that even more. So substance of choice as a risk. So paying attention. So again, I'm going to keep going through these, and you certainly can ask any questions, but I want to be able to continue to have a conversation to expand on some of the slides that aren't just so concrete. So these are pretty concrete PowerPoints. You have the statistics, you have the information, so that when you're working with somebody, you're able to just look at it to identify where marijuana is versus cocaine. Opioids obviously are significantly higher, and alcohol is one of the more significant. So when somebody's doing alcohol and opioids, I'm paying attention differently. I'm also sharing the information, because I want them to know that if you're experiencing this, some of this is just the result of that post-acute. Some of this is just the result of alcohol. So in the beginning, when I had that young adult that was increasing in her suicidal ideation, And I asked her, I said, are you drinking? She said, yes. And I said, so I need to ask you again, what is it that you want? Do you want to change this? And it's okay no matter what, right? People can get attached to the suicidal thoughts. It can breed comfort. It's familiar. I said, are you wanting to get rid of them, or are you wanting to protect them? And in that moment, she's like, I don't want these. And I was like, then I'm going to have to ask you to stop drinking. Right? She did not have an alcohol use disorder where I had to worry about detox and seizures. So she was just drinking enough. I'm going to have to ask you to stop because it's going to increase that. And she was like, oh, I didn't know that. That's why those conversations are important. The link between depression and suicidal behaviors and those with substance use disorders are particularly strong given the high comorbidity. And now we have the intersection of all of them. So I'm overlapping this with partner violence because this also increases it. And so again, I'm not going to do a training on domestic violence and partner violence, but it is important to recognize that violence towards a romantic partner is also an important predictor for suicidality. So physical aggression towards a partner was associated with higher levels of suicidal ideation than was aggression towards a non-partner. So this goes to the attachment theory. This goes to the foundation of people feeling alone, right? So violence has its own learned experience and physiological, assumptions as to how to behave when I feel this way. And so I'm not judging it. I'm not condoning it. I'm not given a particular training on it. But knowing where substance use and trauma is, that when we see partner violence, they're at a higher rate of suicidality. So a more appropriate assessment would need to be done if you had somebody that had that comorbidity or history of partner violence. Another thing that needs to be looked at today is COVID. So again, the coronavirus disease has been associated with mental health challenges. So we are looking at those that are having higher increases of substance use and elevated suicide ideation. So again, I want people to recognize, because there's a lot of people that are like, I don't know what's happening to me. COVID is that, as I had mentioned earlier, different personalities have different vulnerabilities as to their experience of how they have managed COVID. And some people have been, less impacted, and some people significantly impacted. Some of that is personality, some of that is the environment to which they are in, some of them is as a result of these experiences. But when we're looking at close to 41% of respondents reported at least one adverse mental health or behavioral health condition as a result of COVID. And those who had reported seriously considering suicide in the last 30 days was at 10.7%. So this is the time to be asking. There's a lot of first-timers in treatment. I know we've seen a significant intake or uptake in first time in treatment, that the comorbidity of the feelings of anxiety and depression and suicidality need to just continue to be assessed because the experience of COVID is leaving people feeling overwhelmed.
Someone had mentioned that their clients is experiencing an enormous increase in the use of methamphetamines. Is there anything specific to TIC for this population?
So, I mean, there's nothing more specific in regards to trauma-informed care for somebody that's using methamphetamine versus opioids versus cocaine versus alcohol. But they're using a stimulant, so a pretty significant stimulant. So I think when you're using a compound, and that's the important piece, is that if we help somebody to understand, so when you are using substances, when it goes into a substance use disorder, your brain has reorganized the hierarchy. So sometimes, again, when we get caught in the behaviors that somebody's engaging in, I always encourage people, think of if you were, dying of hunger or thirst, and what you would go to, what lengths would you go to in order to satiate that need. Now, recognize that when substance use occurs inside the brain, it actually reprioritizes above food and water. This is why a lot of times you'll hear people saying, they haven't eaten in weeks, or they're not drinking fluids and they're super dehydrated, because the brain has actually superseded the substance to be more of a priority than food or water or shelter. So I'm going to treat the methamphetamine, but I'm also going to start giving them the same trauma-informed care. So I'm still going to help them to understand what those things are. Their drug of choice is just that. And sometimes you can find out what that is. You know, I'm always interested in where they were before they started using substances, you know, when we're talking about this assessment, because it allows for us to kind of figure out, how did we get here? You know, how did you choose a stimulant versus a depressant, you know, and those different kind of things. But as far as trauma-informed care, we wouldn't treat the substance any differently, but you would treat the substance differently. Hopefully that made sense. So the screening and the assessment, all individuals should be screened at the intake. The screening and assessment should be part of nursing and a medical evaluation as well. So again, we know that somebody that has chronic pain, you know, all of the treatment providers should be integrating and doing integrative care. So medical, clinical, everybody should be having a collaborative contribution to the experience. Chronic pain can also increase suicidality, right? So making sure that we're doing the appropriate level of assessments, that if somebody scores, you know, we do the Connor, if somebody scores, or the Connor, I apologize for that, that is not the right one. The Columbia, the Connor is for ADHD. That when we do those things, that we're making sure that all parties are involved in it, that medical and nursing, particularly for substance use, is also going to be involved, because post-acute withdrawal can increase some of the symptoms, because a taper can increase some of the symptoms. So we're making sure that all levels of the individual are being assessed and looked at for risks. So when we look at the risk factors, to include questions about prior violence towards others, sometimes people do not look at that. Past treatment episodes and what they were there for, proximal and distal stressors that may be a contributing factor. So right now, I will say being furloughed or losing their jobs and not paying their mortgage have increased those risk factors for a lot of those accessing substance use treatment. Changes in health and physiological and disease status, losses conflicted, these are all risk factors. The continued assessment, the history of violence or abuse, history of suicide, ideation versus intent versus plan. These are all things that also, for an assessor, should be trained and supported so that they have those. These are the different screening tools. Different organizations use different skills or tools. The BEC is used for suicide ideation and also has their depression inventory. But when you're looking at them, that you're able to assess and then take the next best steps. What kind of interventions are being used to follow risk assessments? For example, collaborative creation of a safety plan, referrals for additional treatment. Yeah, so if there is an addition, you know, if somebody scores, typically what happens is that when you have a higher score on any number of them, and again, different assessments do it differently, then it prompts a further assessment. So if you have these risk factors that increase the level of acuity and risk, then you're prompted to do an additional assessment. And so that might be, if a safety plan is warranted, it might be involving family members and external resources. It might be followed by a medical or psychiatric evaluation. We oftentimes in the initial will have medical to determine if this is part of, if somebody's coming off of methamphetamine, which somebody had mentioned earlier, they do have a higher level sometimes where they present more suicidal or more aggressive, but it's part of their post-acute withdrawal. So it became less psychiatric and more medical. So we're making sure that we're assessing it. We're determining whether or not somebody needs to be on observation for every 15 minutes, a one-on-one, every 30 minutes. So all of those things until you can get a baseline that would allow for you to either make a decision of a higher level of care or that they can be stabilized in the level of care that they are currently in. So we have 4 minutes. So I'm going to quickly go through some of these interventions. Again, if there's questions that you have on these PowerPoints, I love when there's a lot of questions. So I'm always a fan of those, but I realize that it sometimes can prevent us from completing the entire PowerPoint, so I apologize for that, but I do love it because I think that the questions are always indicative of what everybody's kind of thinking. So interventions, empathizing with the suicidal wish, similar to what I had said with this young girl. You don't need to be angry at it. It is your body's attempt to doing what it thinks is in your best interest. And so we just need to create options. So asking, what a life worth living for, which is a very DBT thing to say, to validate their experiences, their pain, their emotions, to identify their strengths, reinforcing any non-suicidal responses, and then highlighting the model that suicide may serve for other loved ones. So all of these things become a part of some of the interventions. Obviously, you're not going to validate that suicide is an effective option, but I can certainly validate that your thought process might think that way. And so we're trying to keep you from that. So I always kind of say, when I talk to people, I always say it's like a 0 to 10. Everybody thinks that it can go from 0 to 10 really quickly, and it can't. Our brains don't operate that way. But we might have somebody, particularly in an inpatient or in various levels of care, that maybe they're starting at a 6. So it's a lot quicker for them to get to a 10, where they engage in the behavior. The behavior can be using substances, suicidality. And so I'm always sharing with the patients and with staff, we're trying to keep you from getting to an 8 or a 9. Because when it's so impulsive, it's likely you're going to act. But there's a lot of things that we can do to keep you below an 8. That's connection. I don't want you to feel ashamed if you have to talk about suicidality. If you're having thoughts, I want you to know that there's safe places for you to have these conversations. I want to connect you with hotlines. I want to connect you with, staff, all of these things so that that doesn't become a barrier. MAT has also been utilized. So the use of methadone and, again, buprenorphine should be prioritized within an integrated treatment plan for individuals with opioid use to protect against suicidality, get a commitment to plan of action. Again, incorporating the family as a director of family services, I'm always looking at opportunities to involve families in meaningful and sustainable recovery and healing from trauma, suicidality, substance use, because when we understand things better, we are better equipped to support. If we don't understand it, we engage in the old behaviors. So getting families involved is going to be incredibly important so that they know how to support the actions. Here are risk factors associated with suicide and protective factors. So again, looking at these things, we're wanting to make sure that they have protective factors. We're going to look at risk factors, and then obviously the dynamic and acute risk factors that we need to pay attention to. I'm going to wrap up in just a few more minutes, so we'll do the motivational enhancement. I'm going to skip. So the importance of motivational interviewing and values-based work. You continued to hear me saying this throughout the entire training. I want to know where they are. So there's motivational interviewing techniques, so the MI, which is a formalized skills-based therapeutic approach. If we're looking at motivational enhancement, there's just these overlaps. Is that I want them to start to look at, I can help them to highlight the discrepancies. So I want to be in recovery, but I'm not ready to quit my job. Okay. So then I can start moving in this decisional balance. And I think a few of you had mentioned different things where, I want to be this type A, but I don't, but I hate the feeling of always being so anxious. All right. So the decisional balance is like, so let's figure out, because you're not going to let go of something if it's still paying off. So helping them to find the discrepancies of, so if your goal is this, and I used to have a kid that said this all the time, I want to be off probation, but I don't want to smoke. I don't want to stop smoking weed. Okay. So I'm not going to tell you to stop because it's serving a purpose, but we need to figure out, can we put something else in there? And you have to decide which is more important to you because you can't have both. For a lot of those that have been impacted by trauma, because they can't get to the cortex, they actually do think they can have both, right? They don't logically think it, but they're stuck in the limbic system, so they do think it. I'm just gonna get off probation. You're like, you can't do both. So helping them, finding out which stage the individual is at. So this is where I always like using the stages of change, not just in the substance use, which is where we normally focus, and that's the hardest thing to let go of. I apologize for that. That's a fire whistle. But in highlighting all of their areas of life. So your stages of change, while it might be in the pre-contemplative for their substance use, they might be in the action phase for, going and taking their medication or going to school. And then I want to know what strengths are getting you there, because then we might be able to use those to help you with some of these other areas. The integration of motivational interviewing. So again, articulating the pros and the cons so that they can better process and ultimately resolve their own. I'm not going to do the work for them. I'm only an area, and I say this to people all the time, I'm an expert in substance use. I'm an expert in trauma. I am not an expert in you. So I can provide you information and tools, but you got to help me figure out, and more importantly, you got to figure out how this makes sense to your life, because you're the only one that gets to decide what you want your life to look at or look like. The collaboration you continue to hear. I'm going to hit a couple of them. The case study, I actually utilized her throughout, so we don't need to worry about that. And then this will be the last slide. So additional evidence-based treatment that is effective for trauma, substance use, and suicidality. DBT is incredibly, so this is Marsha Linehan that had created it initially for borderline personalities, which we no longer use that term, but it does a lot of work, distress tolerance skills and emotion regulation skills. It helps people engage in skills to manage the limbic system, and those are my words, so that you can ultimately get them to the cortex. When we start straight with CBT, for somebody that's been significantly impacted by trauma, sometimes they can't, their limbic system, their emotional experience will override their logical. So that's where I like the combination of both. Creating chain analyses where you're able to kind of identify what happened, and then all of these things, because people will say all the time, it just happened. No, it didn't. It's not possible. So helping them to identify all of the things that led to the event, because then there's all these opportunities to do it different. This is incredibly useful within substance use, within trauma responses. I don't need to know the trigger to know that you have been. And then we can start building additional skills. So having said that, I am done. If there are any questions, please feel free to send them through now, and I will do my best to answer them before you hop off. I appreciate you guys being here and answering. There's my information, so if you want to email me personally, you can, and I will answer any additional questions that I might not have been able to answer thoroughly. Thank you for your time. Thank you for doing what you do every day, and I hope you have a wonderful day.
Trish, thank you so much. We always enjoy hearing you present, and we've had a lot of great comments, and you did a great job with answering questions as they came along. If you could just hold on real quick to the audience, we do have an evaluation that we would like for you to complete. Your feedback is very important to us. When I conclude today's webinar, your browser will take you to an evaluation on the FADA new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You'll be prompted to register or sign in to complete the evaluation, and you can register as a visitor at no cost. For CEs to be reported to CE broker for the Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license and prefix number the first time you register. Once you register or sign in, you should be able to complete the evaluation. You will need to enter your information that you've provided for your profile. Once your evaluation has been completed, you will receive a response saying that we have received your evaluation. Again, it does take up to 30 days to get the evaluation results entered and your CEs posted, so please be patient. The evaluation does close on Friday, September the 11th. Again, please enter your prefix numbers and your license number. The PowerPoint and presentation will be available on our website within 30 business days, and we do try to get that up sooner. Once your credits are posted, they're posted to your professional development journal, so we do not send statements of credits to you via email. You'll have to go in and print those yourself. And again, Trish, we do want to thank you for presenting to us today. You shared a wealth of information to us. And we also want to thank the audience for participating, and thank the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation. Thank you.